Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And today we're going to move forward in our prostate cancer discussions, looking at the role of adjuvant therapy in early stage prostate cancer.
Hope everyone had a happy new year, and to everyone on the Northeast, hope everybody does okay with the storm coming tomorrow.
And for those of you who are listening to this in the future, hope you weathered the storm. Last discussion, we primarily went over surgical and radiation considerations and the approach to localized prostate cancer. Today we'll be moving slightly more into a medical oncology area. However, depending on where you work, sometimes these drugs will be prescribed by your urologist or even your radiation oncologist. Although, as we mentioned, many prostate cancers will not have a significant impact on someone's overall survival or mortality, there still are many patients who will have this cancer recur. And when it does, this is incurable, with prostate cancer morbidity approaching 60% at 10 years in the highest risk patient population, namely those with a PSA greater than 25 or Gleason score greater than equal to 8.
So today we're going to be talking about adjuvant ADT, also known as androgen deprivation therapy. This has a very interesting history. It was initially used in the metastatic setting and has been used since the 1940s. Back at that time, they more commonly did castration-induced androgen deprivation, and they actually found that it did cause people who had metastatic prostate cancer to have some improvement in bone pain and improvement in some obstructive symptoms.
The corticosteroids were beginning to be understood, which was in the 1940s, 1950s. Estrogen had been recognized as being prevalent, especially in breast cancer, and analogous to this, androgens were clearly shown to have a role with prostate cancer, which in vitro studies was confirmed to be the hormone of interest leading to the prostate cancer regression with the orchiectomy.
One of the first medical androgen deprivation therapy was known as DES, which is diethylstilbestrol. This used to be used very commonly. However, it was then realized that it caused major cardiovascular toxicity, so it was no longer used. However, the inventors of this, the classic pair Huggins and Hodges, did receive the Nobel Prize for this in 1967 for its improvement in prostate cancer outcomes.
As better understanding of hormonal secretion and the hypopituitary gonad axis became better understood, gonadotropin-releasing hormone began to be the target to better affect testosterone production. It's worth mentioning these agents such as leuprolide or goserelin, which are very commonplace used in North America and in many areas, are very expensive agents. And depending on where you work, you may still see orchiectomy used as the primary way of castrating a patient. There's really no difference whether or not you do medical or surgical castration. However, often when given the choice, patients will prefer the medical route due to it being potentially reversible.
So when we're using androgen deprivation therapy, the goal is to decrease the testosterone, particularly to a level less than 50. This is what we consider the castrate level testosterone. So when people start progressing, even with the testosterone less than 50, that's when we hear the term castration-resistant prostate cancer, which we'll speak about later.
The most commonly used agents that we have are the GnRH agonists. So these work by actually stimulating the initial release of gonadotropin, such as luteinizing hormone. However, by giving continuous stimulation, these do then lead to anergy and eventually decrease in testosterone production within the testes. These are usually given as intramuscular or subcutaneous injections. Goserelin, which is one of the agents, can be given either as monthly or every 3 monthly injections. And leuprolide can be given as every monthly, every 12 weeks, every 16 weeks, or every 24-week injections.
Now, because we said that initially these agents increase the amount of LH being released at first, there is a concern for a tumor flare when you first start the medications. Because of this, patients who are very symptomatic or have a large lesion near the spinal cord and you're really concerned about this flare, we would usually start an androgen receptor blocker such as bicalutamide for about 2 weeks before and 2 weeks after giving the GnRH agonist.
In the early stage setting, this is not so relevant, but certainly in the metastatic disease, patients may have a large burden of disease and you're going to want to limit their flare.
There's also another group of medications called the GnRH antagonists, which also suppress testosterone production, but they do this by directly blocking the LHRH receptor on the pituitary gland. So this essentially gets the same effect of decreasing testosterone, but you don't have that initial LH surge after starting. So if you're concerned about a tumor flare in the metastatic setting, you could also consider the GnRH antagonists rather than the agonists.
Many of the adjuvant and neoadjuvant studies that we're going to be talking about today were run prior to the development of these GnRH antagonists. In general, the standard practice is using an agonist as that has more evidence behind it, but physiologically there should be no difference between either regimen, and slight differences in how they're administered and the side effects. In terms of the side effects related to the LHRH agonists, and we're using LHRH or GnRH agonists sort of interchangeably here, these side effects include hot flashes, fatigue, erectile dysfunction, and ejaculation. They can lead in long-term setting to osteoporosis. Notably, some serious side effects include increased risk of myocardial infarct, with cardiac ischemia being reported in up to 10%, which is very relevant, especially in patients who have baseline risk for cardiac disease. They can also lead to QTc prolongation and, less commonly, seizures.
Another side effect that you'll see sometimes is gynecomastia, which can be particularly frustrating for male patients.
This androgen deprivation therapy, also known as ADT, has significantly been a backbone of therapy and has improved overall survival for our patients. Along with these, we've also seen the role of chemotherapy improving overall survival, namely with docetaxel. So whenever we see drugs that improve overall survival in the metastatic setting, the question is, can we incorporate them earlier and increase the chance of cure for patients with early disease? And the bulk of the evidence we're going to talk about is using ADT, and has led to an improvement in survival in certain patient settings. Chemotherapy, although this has improved disease-free survival, has never shown improvements in overall survival in the adjuvant setting. So we won't discuss that in great detail here today, but we will include in our show notes one of the primary trials that was looked at with docetaxel in the early stage.
So when we talk about people having a radical prostatectomy, unlike in other cancers, when we talk about neoadjuvant therapies to downstage the tumor prior to surgery, in prostate cancer, there really currently is no role yet for like neoadjuvant ADT to shrink the tumor to make the surgery easier. There are trials looking at this, but it's not considered standard of care currently.
When it comes to ADT following surgery, there's limited evidence to support adjuvant therapy as well. This has only been really well studied in patients who have positive lymph nodes at the time of radical prostatectomy. And although this has addition of ADT for some period of time can delay the time to disease recurrence, it has never shown improvements in overall survival. It remains an area of interest, but currently would not be a standard of care. On the other hand, radiation has prolonged progression-free survival in specifically selected patients, namely those who have either T3 disease or positive margins. This has not improved overall survival, with the exception of one of the 4 large randomized control studies on this subject.
So most of the benefit with ADT is when we use it with radiation therapy rather than surgery. One of the first studies looking at this was the EORTC 22863 trial, which looked at about 400 patients with either T1 or T2 grade 3 disease or T3, T4 any grade. This randomized patients to radiation versus radiation plus 3 years of ADT. And it was positive for overall survival. The 10-year overall survival was 40% in the control group and 58% in the ADT group.
It's translated into a hazard ratio of 0.6. And looking specifically at 10-year prostate cancer-related mortality, this was also improved at 30% versus 10%. Although there was an increased risk for cardiac disease and mortality in the patients who received the ADT, this was still overwhelmed by the absolute benefit in prevention of prostate cancer death in this high-risk population.
This was followed by another study, the RTOG 8610 trial, which again looked at almost 500 patients, this time either T2 to T4, N0 or N1, and randomized patients to radiation versus radiation plus 4 months of ADT. This had an improvement in 10-year prostate-specific mortality, 23% in the ADT group versus 36% in the control group. However, the overall survival benefit was not statistically significant in the study.
So the actual follow-up question would be, does the duration of your ADT matter, where we see overall survival with the 3 years, but not with the 4 months? And there's been 2 landmark trials comparing duration of ADT. The RTOG performed primarily in North America, looking at 4 versus 24 months of ADT following radiation, and a European study that was looking at 6 months versus 36 months of duration. These duration trials did, in addition to the high-risk patients, also include some that would meet the intermediate risk criteria that we have today. And Although the overall survival was not statistically different in the RTOG trial, looking at 4 versus 24 months, it was not non-inferior. So potentially overall survival is shorter in the 6 versus 36 month duration population. Follow-up meta-analysis of this, called the MARCAP study, MARCAP, did indicate a benefit in metastasis-free survival and overall survival with the longer course of ADT. In this study, the overall survival was improved from 57 to 63% at 10 years, and the 10-year metastasis-free survival was 55 versus 47%. Keeping in mind, once again, there was a number of intermediate risk patients in this population, and it's unclear to what extent of benefit those patients were deriving.
In regards to the practical aspects and logistics of this, some people start the ADT approximately 2 months before beginning radiation. There have been specific studies looking at the timing of ADT with regards to radiation. However, the studies are conflicting and it doesn't really seem to affect the outcomes.
So depending on where you work, you may see the ADT initiate a couple months before, at the time that radiation starts, or even after radiation ends. And it will likely vary by provider preferences and logistics depending on your cancer center arrangements. In terms of whether it's best to select a longer course or shorter course, certainly for high-risk patients, it looks like using a 2 to 3 year course is more likely to improve your overall survival and disease control. For patients with intermediate risk disease, as their likelihood for recurrence is less so than those with high risk disease, a 4 to 6 month duration of ADT seems to be likely acceptable. In patients with favorable intermediate risk disease, decision on whether or not to incorporate ADT will be made on a case-to-case basis and often will take into account patients' comorbidities and competing risks to their mortality. There has been data in patients who have a history of cardiac ischemia, which suggests a higher risk of cardiac death during the course of ADT. So for patients with history of cardiac ischemia, especially those with a recent MI, it is important to be very cautious with the addition of adjuvant ADT, as that benefit for overall survival from prostate cancer death may be outweighed by the risk of a recurrent cardiac event. Many of the trials that we've just discussed took over 10 years before an overall survival benefit could be shown. And as this is our gold standard for any intervention when it comes to oncology, this can be very limiting in terms of time from developing a new strategy to finding out whether or not that strategy worked. And usually in the interim, 2 or 3 more approaches have been tried. This has led for a lot of inconsistency between many of the trials that have been used for prostate cancer, where radiation treatments may vary from time to time, and the drugs being used during ADT will vary as well. Due to this, a surrogate marker was highly sought after, and although none of the individual trials on their own developed a strategy to validate a surrogate marker, there was a meta-analysis called the IceCap study led by Dr. Sweeney that looked at the role of metastasis-free survival. And this meta-analysis had access to individual patient data that made up 21,000 patients, and they did find that being able to prevent an event of a distant metastasis, whether that's in the lymph nodes or further, does correlate with overall survival. So this has since been used as an endpoint for all of the early stage adjuvant trials, and it's thought to be valid enough to help justify an endpoint that happens a few years prior to an overall survival event, hoping to shorten the time between new strategies and these being incorporated into patient care.
Due to the success of some other agents in the metastatic setting, there have been attempts to push these up into the adjuvant setting as well. The first drug that we're going to talk about is called abiraterone, which is both a 17-alpha hydroxylase inhibitor and a 17-20 lyase inhibitor. If you remember back from the medical school days when we had to memorize the pathways for how both glucocorticoids and androgens get made, you may remember these 2 enzymes and that they're important for both androgens and glucocorticoid production. So it makes sense that blocking these enzymes would lead to a decrease in testosterone. However, then you have an unopposed mineral corticoid excess. So in order to prevent that, when you take abiraterone, you also have to take prednisone with it, because otherwise you could have mineral corticoid excess, which can lead to hypertension, fluid retention, hypokalemia. So patients take both abiraterone and prednisone.
Although the androgen deprivation therapy that we've discussed so far do suppress gonadal-testosterone, and the adrenals in general produce a minimal amount of testosterone in the big picture, this residual testosterone that is produced can still play a role in prostate cancer progression. In the metastatic setting, one of the main areas of resistance is that prostate cancers do increase the number of androgen receptors in each tumor cell. So they become more sensitive to even the smallest amount of testosterone. So by using this drug, by also suppressing the adrenal testosterone production, we get the testosterone levels even lower. And this has shown improvements in outcomes in those patients. And we'll be discussing that in more detail during the next discussion. We previously had achieved this using an old-fashioned antifungal, ketoconazole. But due to many toxicities with this, as well as its reversible binding affinity for the CYP17A1 enzyme, abiraterone has been much more effective at achieving our goal.
A few of the major toxicities of abiraterone are hypokalemia, elevated liver enzymes, and hypertension. Some common things that we see that you want to keep an eye out for during treatment.
Some patients also develop lower extremity edema, and there have been higher rates of atrial fibrillation compared to control in the clinical trials. In general, when we start a patient on this new agent, we would be monitoring blood pressure, especially in the first couple weeks, and typically labs would be checked either 2 weeks or 1 month after initiating therapy. Patients who tolerate this therapy initially tend to tolerate it moving forward, and occasionally we can move to an every 3-month follow-up once patients are tolerating this medication well. One last thing to mention is the dose of prednisone that we give with abiraterone will be different depending on whether or not we're giving in the hormone-sensitive state, so in either adjuvant or initially in metastatic setting, or in the hormone-resistant state for treatment-refractory disease. And in the hormone-sensitive state, like adjuvant therapy, which we're talking about today, we would be giving it as 5 milligrams daily, and that would move up to twice a day in the more resistant disease.
So the study looking at abiraterone in the adjuvant setting is a little bit complicated. It's part of the STAMPEDE group of trials, which were run by the United Kingdom and Switzerland. This was a group of multiple trials, both in the metastatic and adjuvant settings, and included both ADT, abiraterone, and some trials included enzalutamide. Today we're just going to be talking about the adjuvant trials. There were 2 trials that were actually ended up being combined to look at the addition of abiraterone to ADT. The first one included almost 2,000 patients. It looked at the addition of abiraterone and prednisone to ADT, and there was also a group that looked at the combination of abiraterone, prednisone, and enzalutamide, which we'll speak about in a minute, is an androgen receptor blocker, adding that to ADT. The second trial included about 1,000 patients and was only looking at abiraterone prednisone with ADT versus ADT alone. And they ended up analyzing these trials together and combining the control groups because they had very similar characteristics to make their comparison.
Each of these studies had the exact same inclusion criteria, and while they were being run, further data had come out in the metastatic setting showing that the addition of enzalutamide to abiraterone did not seem to add a whole lot of benefit. Because of that, the authors felt confident that they could really be focusing on what's the benefit abiraterone's adding. So even though one of the trials had an extra drug, this did not seem to likely improve overall outcomes. So they were able to be studied at the same time with some additional sensitivity analyses performed to ensure no interaction.
So to be eligible for this trial, patients had to be considered high risk, which was either lymph node positive or you had to have at least 2 of the following: T3 or T4, Gleason group 4 or 5, or PSA greater than or equal to 40.
In these trials, ADT was given for 3 years. These are high-risk patients, so that would be standard of care. Radiation therapy was mandated for any patient that was node negative and encouraged for any patient that was node positive. So for patients who are lymph node positive, the evidence for radiation therapy may not be so strong, and different areas will differ in their opinion. However, the vast majority of patients did end up getting radiation, regardless of their lymph node status.
The primary outcome was metastasis-free survival. So at the latest follow-up, the 6-year metastasis-free survival was 82% in the abiraterone group versus 69% in the ADT alone group. There's also an improvement in overall survival. 6-year overall survival, 86% versus 77%. And 6-year prostate cancer-specific survival, 93% versus 85%.
40% of the patients were lymph node positive. It appeared that the survival began to separate when you look at the Kaplan-Meier curves around the 2-year point. When looking at the subgroups, it appeared that nearly all patients benefited when we look at the metastasis-free survival, with just the subgroup with an ECOG score of 1 to 2 that seemed to have less of a benefit from the intensification of therapy. So because of this, in patients who would meet the inclusion criteria for the STAMPEDE trial, we would be intensifying our 3 years of ADT to also include abiraterone, which is given for 2 years. just briefly on enzalutamide, we'll be talking about this a lot more in the metastatic setting. This is a novel anti-androgen, so this binds directly to the androgen receptor. It gets around the resistance in AR1 mutations that make them increasingly active even in the absence of the presence of testosterone. Much like our fulvestrant for breast cancer, these anti-androgens bind directly to the androgen receptor and lead to degradation and prevent it from translocating into the nucleus, leading to. As with abiraterone, these did have a predecessor, bicalutamide, also known as Casodex. Bicalutamide is still a drug that we use today in select patients, or for preventing that testosterone flares we discussed earlier. These are more potent and are similar to two other agents, darolutamide and apalutamide. Once again, we're going to talk about these drugs and where they have shown benefit, unlike in the adjuvant setting during our follow-up discussion. Enzalutamide in particular does have toxicities. It causes hypertension in about 12% of the patients, presence of rash, diarrhea in 20%, edema, significant fatigue, risk of falls, and even seizures in some patients. And it's very important to be cautious with enzalutamide in elderly or patients with some cognitive compromise, as it can lead to a significant decline in an already frail patient.
So now that we've spoken about the adjuvant treatment course for intermediate and high-risk prostate cancer, we'll briefly get into what we do at relapse, particularly local relapse. There's different definitions for relapse depending on if you were treated with prostatectomy versus radiation. After radiation, you may still have some PSA because you'd have some prostate tissue left. So they developed a criteria called the Phoenix criteria, which is a PSA rise of 2 nanograms per milliliter above the nadir after radiation. And this usually has to be repeated to confirm this. You wouldn't just use one value to confirm recurrence.
Following a radical prostatectomy, as the entirety of the prostate has been removed, you have a much lower threshold for calling PSA recurrence, and this would be a rise to a level greater than 0.2 following surgery. Of course, the question when the PSA does begin to rise, is this a true positive, and is this due to local disease recurrence or distant disease recurrence? Previously, our imaging techniques were not overly sensitive, and a lot of the clinical trials looking at interventions at the time of PSA recurrence are a bit limited because they may have missed metastatic disease. Nowadays, with the high-quality MRI prostate and PSMA PETs, we've increased our sensitivity and we're better at identifying whether or not there's local or distant disease recurrence. And this may have an impact on how we look at some of the trials that had led to our current practice.
Yeah, that's a good point. Our term biochemical recurrence, where you only have elevated PSA and nothing on imaging, definitely doesn't happen as often now with the better imaging techniques. If someone has a rising PSA after treatment, you would want to do one of the newer PSMA PET CTs if you have access to it, or a CT bone scan if not, to rule out distant metastasis. If there's no evidence of that, then you'd consider MRI prostate to look closer at the prostate gland. And if any area is positive on any of those scans, you would want to confirm this with a biopsy.
Sometimes, despite even with imaging, we have only the PSA rise altogether, and there are certain approaches that are sometimes used for a pure biochemical recurrence. If a patient has previously had a radical prostatectomy, there is single center and retrospective data looking at giving radiation to the prostate bed. These have had varying results, but subgroup analysis of these small trials have found that when radiation to the prostate bed is beneficial, it seems to be with the PSA is less than 0.5 in patients who've previously had negative surgical margins and negative LVI. So a very select patient who've had a rise in their PSA after radical prostatectomy, but not a rise too high. And in these selected patients, given the limitations of single center studies, have shown to have a 5-year recurrence-free survival of greater than 70% with the addition of radiation. Whether or not to include ADT when you give radiation in the salvage setting is also based upon very limited evidence.
So that's if someone had recurrence after prostatectomy. Now, if somebody has recurrence after receiving radiation, there are some salvage options available. Many of these options are performed by our urology and radiation oncology colleagues, such as prostatectomy, cryotherapy, brachytherapy, radiofrequency ablation. There are also some newer techniques such as high-intensity focused ultrasound, also known as HIFU, which can be done to target a specific area in the prostate. If somebody's not a candidate for these options, then you could consider systemic therapy.
It's important to keep in mind that when the disease does begin to recur after definitive therapy, these salvage therapies, although in some patients may lead to a long recurrence-free survival, in most patients, whether you have early salvage or late palliative-based therapy will have the disease come back. So selection of treatment will be really taking into multiple factors, such as the time it took before the PSA began to rise. Was this something that started 6 months after your definitive therapy or years later? Those that are years later may indicate a more indolent disease that may not need as much aggressive therapy right away, as well as patient characteristics. Many of these patients are now maybe 2, 3, 4 years out from their definitive therapy, maybe even over 10 years out, and a lot of things can change in health over 10 years. And it may just be as reasonable to continue to follow the PSA, especially as we do have more effective, tolerable therapies to offer in the palliative setting. And with that, we'll kind of just go into some bottom lines before closing out. For patients whose upfront therapy is a radical prostatectomy, there is a potential role for adjuvant radiation in those with T3 disease or greater, or positive margins, although this has not shown overall survival. Androgen deprivation therapy has not shown a clear role following such a surgery.
However, in patients receiving radiation therapy, ADT can be offered for patients with intermediate and high-risk patients.
In these patients, an overall survival has been shown, extending out to 10 years. The exact length of ADT remains an area of debate, but certainly in high-risk patients, it appears that a 2 to 3 year duration is superior overall.
The addition of abiraterone to high-risk patients, such as lymph node positive, or at least 2 of the following, T3, T4, Gleason group 4 or 5, or PSA greater than or equal to 40, has been shown to have an overall survival benefit when added to ADT in the adjuvant setting for 2 years.
There is no added benefit of further intensifying beyond abiraterone with the addition of enzalutamide. Keep in mind that the abiraterone is given for 2 years, while the ATT is given for 3 years. Docetaxel, which is an effective agent in the metastatic setting, has not shown improvements in overall survival in the adjuvant setting for prostate cancer.
If someone has a rising PSA after treatment, you would want to obtain staging imaging such as a PSMA, PET CT if available, or a CT and bone scan. And if no distant mets are found, you'd want to get an MRI of the prostate. There are salvage options for patients with a rising PSA after treatment. After prostatectomy, there's evidence to support salvage radiation to the prostate bed.
Following radiation, should the PSA rise more than 2 nanograms from the nadir, there are a few different options such as a salvage radical prostatectomy, brachytherapy, or cryosurgery. Of note, surgery can be challenging following definitive radiation to the prostate. It's very important not to underestimate the cardiac toxicity with ADT. A 10% risk of cardiac and ischemic disease is not insignificant, especially when this is further exacerbating patients with underlying risk of coronary disease. And it's very important that if you're prescribing ADT, to be aware of the benefit you're adding, as well as the potential risk based upon the patient in front of you.
Thanks everyone for listening, and again, please feel free to give us a review or leave us some feedback.
We appreciate everyone who's been following along so far. And we'll see you for the next discussion around the metastatic setting, all the new agents that have been coming out for better outcomes in our patients with incurable prostate cancer.
Have a good night.
Take care.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
The opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.